of all, I would like to thank Professor Mohammed Fawzi for this kind invitation. It's a really interesting session and really interesting to me in particular because I really believe in HIFU in gynecological procedures, so I'm really interested in this session. Thank you, Professor Mohammed, for this elegant conference. And our next speaker will be Professor Martijn Boomsma. Yes, Professor of Radiology at Isala Hospital, Holland, the Netherlands. He has strong research interest in MRI, HIFU, CT, metal artifact reduction, quantification in radiology, and special interest in artificial intelligence in radiology. Professor Martijn will be, he's there, huh? He's not recorded? Recorded? It's recorded. It's a recorded lecture? It's a recorded lecture, actually.
On HIFU.
It will be about magnetic resonance guided HIFU in pre-menopausal women. Where do we stand?
Without this team, there would have been no implementation of HIFU in hospital. We need to work very closely, in close collaboration. If you have no friends, it's difficult to work together, so drink a lot of coffee, tea, or soda, or water for that matter. And then, anyway. Good morning, my name is Martijn Boomsma. I'm a radiologist from the Netherlands. I would like to thank Professor Fawzi for the invitation. Unfortunately, I was not able to attend live, but I'm glad that I've been given the chance to meet you virtually and give you this presentation of where we stand actually in Isala when we treat women who are premenopausal and suffer from fibroids with MR-HIFU. And the undertitle is, Where do we stand? First of all, I would like to present my team. Without this team, there would have been no implementation of HIFU in hospital. You need to work very closely, in close collaboration. If you have no friends, it's difficult to work together, so drink a lot of coffee, tea, or soda, or water for that matter. And then, anyway, get to know each other, have some fun, because treating patients minimal invasively or non-invasively is absolutely fabulous. The benefits of MR-HIFU are numerous. It's non-invasive, you don't need general anesthesia, it preserves the uterus, there's no radiation involved, it can be done in a daycare setting, there's absolutely short recovery time, a high safety profile, and about 60% of patients are eligible. So, the main question is, why not? Well, that's the technique. Not all patients are suitable. Expectation management is not always very clear. There's this gold standard you have to deal with. You need to counsel the patients who often do not know about HIFU. You have to work together as different medical specialties, and that's always a challenge, and you need backup from your organization. We learned a lot while implementing HIFU, and the lessons that we learned can benefit your practice. So please go to this paper, and you will see that you will need about 23 patients to get the hang of it, but there are numerous other tips and tricks and appendices that you can benefit from, and maybe you can get good results more quickly. But then there's still the challenge of reimbursement. Without reimbursement, it's very difficult to treat patients, and because in the Netherlands we don't think we should send people bills at home, we are not very commercially, like for example in other countries, and mostly patients do not have this kind of money for these kind of treatments, especially if you can get another treatment that's reimbursed and doesn't cost you a thing extra. So we need to get reimbursement, and this is easier said than done. You need cost effectiveness analysis, health technology assessments, and so forth, and so forth. All right. And then you have to deal with all the other current treatment options like medication, hysteroscopy, hysterectomy, myomectomy, uterine artery embolization, and you can perform HIFU by means of MRI guidance, but also ultrasound guided. And I think Professor Vos has a lot of experience with that. So, why MR-HIFU? Because MR is the Rolls Royce in radiology. It's non-invasive. You can see absolutely in clear images what you are doing, where you are working. You can get temperature feedback, so you can avoid collateral damage, such as near field or far field heating. There's quite a lot of experience in MR-HIFU. It's been out there since 2004, and it started off in the United States of America. And since 2016, we started off with these kind of treatments in the Saal Hospital in the Netherlands. The patient is lying at the table on her belly. The HIFU transducer is placed in the tabletop, and you have an interface to plan the treatment and to follow the treatment. By MR, you can obtain anatomical data for the suffocation planning, and you can get real-time thermometry feedback. The HIFU transducer is a convergent bundle and deposits acoustic energy 10,000 times of a normal divergent ultrasound beam, which is used, for example, for a normal abdominal ultrasound of the gallbladder, for example. The Sonolief console gives you the opportunity to plan the sonication and set for ablation parameters in 3 directions. You can treat the whole fibroid by placing adjacent sonication cells, and you can vary with the amount of volume you want to ablate depending on the type of uterine tissue. The far field and near field needs to be controlled, as we don't want heating up of the plexus sacralis, we don't want abdominal wall burn scars, which we have seen in the past, but that was in the first generation when there was no abdominal cooling in the table involved. And since we've upgraded the system to the V2, we have not seen these complications anymore. So it's virtually without any complications. The focal point is most important. You get temperature feedback. Red is good because you ablated, and red is wrong if you are in the far or the near field, because then there's too much heat deposit over there. So how do we check whether or not we treat the patient well? Well, we assert the ablation volume. We call that the non-perfused volume. We assess it by giving IV contrast after treatment, and we compare it with the pre-treatment CET1 weighted imaging. And the higher the MPV, the more clinical effective we are. The higher the MPV is, the lower is the reintervention rate. So, aren't there any challenges left? Well, of course there are many. Firstly, we looked at clinical effectiveness in general from other groups, and we looked at unrestricted treatment protocols instead of the previously performed systematic reviews about restricted treatment protocols, because in the beginning it was thought it was better not to damage the myometrium if you got too close to the myometrium at the outskirts of the fibroid. But now we know we can deliver a thermal lethal dose at the periphery of the fibroid without damaging the myometrium. And we've seen that the reintervention rate in that case, in an unrestricted protocol, is between 0 and 21% after 3 to 34 months. And the symptom severity score is decreased by 60% in 12 months, and the quality of life increases about 30% in 6 months. We looked also at a retrospective study, not just from the literature, but our own retrospective study in the University Medical Center in Utrecht, in which we could compare unrestricted protocols in the beginning with restricted protocols in the beginning and unrestricted protocols in the second part of this patient cohort. And we saw that the reintervention rate in an unrestricted protocol was only 18%, and that's comparable to the uterine artery embolization, for which reimbursement is obtained in the Netherlands. A lot of women have fibroids in the fertile age, and some of them still wish to conceive. And sometimes there's no explanation for why a couple cannot conceive and get a pregnancy and live birth, and maybe it's only myoma that gets in the way. So we got some referrals here, but we actually did not know what was the clinical effect of these treatments? Well, the good news is there are a lot of HIFU babies out there. But the studies are not very homogeneous, they are not well designed, they're mostly anecdotal. And well, we see pregnancy percentage rates between 7 and 36%, a miscarriage rate between 8 to 50%, and time to pregnancy between 0 and 36 months. We needed to make improvements on eligibility and technique. Therefore, we developed a clinically evaluated 3-step modified manipulation protocol for MR-guided high-intensity focal ultrasound of uterine fibroids. By filling and emptying the bladder and filling the rectum with a substance, it's quite thick and gives more pressure to the uterus, we were able to massage the bowels above the uterus and let the uterus get in a close interversion with the abdominal wall in order to be able to be treated. And we increased the eligibility and we increased non-perfused volume percentage. We don't always know for sure which patient we can treat or not. It depends on the Funaki classification. Funaki 1, 2, and 3. 1 is black, 2 is intermediate, and 3 has high T2 signal intensity. But we know that some patients with Funaki 3 can be treated, and we know that some patients with Funaki 2 cannot be treated. So this is not an absolute good prediction model to select patients, and we are really doing our best by use of multi-parametric MRI scans to characterize the uterine fibroid tissue in order to be able to make a prediction model. You will hear more about that in a few months, I think. Anyway, you can dry out the patient, the fibroid, by giving carbetocin. It enables us to heat up the fibroid more quickly, and you get shorter sonication times, and you reach the thermal lethal dose much more quickly. And you know, time is money always. So also in this case, you don't want to treat the whole day a patient. You definitely want to treat 2 patients a day for the minimum in this setting. So, about eligibility and screening, you need to be older than 80 years. Pre-menopausal, you have the symptoms, not more than 5 fibroids. Obesity is a problem because the maximum depth of the beam is about 10 centimeters to maximum 12. You cannot be pregnant. If you have a suspicion of malignancy on MR imaging, you shouldn't go there. If there's a dominant adenomyosis, maybe you would like to treat the adenomyosis, but you're not going to treat the fibroid with a good result because the patient is suffering from adenomyosis rather than from the fibroid. If the subcutaneous fat layer is too big, more than 4 centimeters, don't go there. If there's subserosal stalked or submucosal myoma, don't go there. Lower than 2 centimeters, don't go there. If it's more than 12 centimeters distance between the transducer and the myoma or the backside of the myoma, don't go there. Calcified fibroids, those are fibroids who are not really viable, don't go there. And if there's no contrast enhancement, don't go there because it's not a viable structure. So here you see the Funaki classification. On the left, Funaki 1, it's completely black in comparison to the abdominal wall. Funaki 2, it's a little bit high signal with regard to the abdominal wall, but not with regard to the myometrium. And the Funaki 3 means such a high T2 signal intensity that it is exceeding the T2 signal from the myometrium. So preferably you would like to treat the Funaki 1 and Funaki 2 patients, and we don't have anything better yet at this moment, but we hope to provide you with some guidance in the future. So you need to prepare the patient. You have to give her an enema, a catheter in the bladder, an IV line, and some pre-medication. It's being done under sedation, and we don't need a lot of post-interventional monitoring. So the reimbursement, which I already talked about, is a challenge. We have decided to perform a study. It's called a MOHP study. It's a well-designed randomized clinical trial that investigates the long-term cost effectiveness, and patients are randomized in a 2-to-1 ratio, and the outcome measures are quality of life and cost effectiveness. We do this by patient file questionnaires, and in the follow-up we also make a 6-month follow-up MR scan. And for those who are really interested in the ins and outs of this study, You can also find this in the J and ER research protocols, in which has been fully detailed described. So the take-home messages are: why should you consider MR-HIFU? Well, you should consider MR-HIFU if you want a uterus-preserving intervention that's absolutely non-invasive. You can benefit from the lessons we have learned and the continuous improvement we are making in the field. And remember this, at high non-perfused volume, that means satisfied patients. I'd like to thank you very much for your attention, and I'm open for suggestions or questions after this presentation. I hope you've enjoyed it, and hope to see you next year in Cairo, in live in person. Thank you very much.
Dr. Fauzi.
Thank you, Professor.
Dr. Fauzi.
We're going to have
Dr. Fauzi.
Q&As.
Ladies and gentlemen,
Dr. Fauzi,
Yes.
can I have a question for the presenter?
Any questions?
Yes, please. Excuse me, thank you for your illustrative and informative lectures. I appreciate your unique work with MR-guided HIFU. But I have a question regarding the limitation of the patient choices. You make a lot of limitation related to the size. You only treating more than 2 centimeter, related to the distance from the skin. Of course, this is related to the MR-guided HIFU, not a general indication. As we working with ultrasound-guided, this limitation is, the scope of patient is much, much larger. What do you think about this? Because sometimes we treating multiple fibroids, and we can ablate a fibroid with 1.5 centimeter in our way, and we can reposition the patient or reposition the machine with ultrasound, so it's more applicable to do a more patient. What do you think? What about your experience about this? There's no voice.
It's muted. Can you hear us? Can you hear us?
Professor Martijn, can you hear us?
I can hear you, yes.
Okay,
Yes,
now it's
now.
okay. Back.
Professor Hamid, can you repeat your question, please?
No, I've heard the question.
Okay.
Do you hear me?
Yes,
Yes,
we
we can hear you very
Okay,
well.
good. Okay, so my first reaction is that it might be complementary. So I think to be practical is always the best. But the question is, you are stating, can you really treat all the patients with ultrasound guidance or not? Do you always have full ablation or not? So we should compare these data in good comparative trials, for example, or from cohort studies. I prefer HIFU at this point in time because I want HIFU to be a renowned intervention. And MR gives you unique opportunities to say something about the fibroid tissue, for example. You can do multi-parametric analysis. We can also use it for other interventions, for example, catheter-guided embolization protocols for tumors in the liver, for example, and then you can actually quantify whether or not the tumor has taken up all the beats, for example. And the temperature feedback is very important, that you don't make any damage. So it has limitations, for sure, and I have mentioned them, but I am not an expert on ultrasound, but I can imagine that there are some limitations there as well. And maybe in the future we should, just consider it as complementary strategies. But the history has taught us that people like easy in life. So if your method is easier, maybe you will be the winner. I just don't know.
Yes. Also, I want to ask you about your experience for treating adenomyosis cases, because ultrasound guided HIFU, if we have a diffuse or focal form of adenomyosis, we have a good results. Not as fibroid, of course, but it's a very promising results. You have any experience about this?
No, not yet. I'm willing to do this, but I am restricted at the moment in time here in the Netherlands that these treatments cost money, of course, and I'm already happy that I can do these kind of treatments without reimbursement. So we're actually paying it for ourselves in the hospital in order to run the My Choice trial. I would really much like to extend the indications, but not only, for example, to adenomyosis, but also for women who want to conceive. So there are more indications than we see here now. You could also treat, for example, endometriosis in the abdominal wall, which is now being done with surgery, or desmoid tumors from the abdominal wall. So there are quite a few extra indications. I think HIFU would be excellent, but yeah, we have some pockets, but at a certain point in time they get empty. Eh? So in the end, so I want my primary goal is get one treatment reimbursed, and then the rest will follow.
Thank you very much. We appreciate.
Can I ask a couple of questions, Professor Martijn? Being a gynecologist, I'd like to ask actually two questions. Do the gynecologists in the Netherlands cooperate, or are they convinced? Do they refer their patients or not for myomas? Because, as you know, maybe the practice in the Netherlands is different than our country, because it's institution-based, actually, but in Egypt, it's individual-based. So do you find any cooperation? That's the first one. And the second one, any experience with ovarian ablation or castration, castration for those with breast cancer?
To the first question, I'm very happy that I have great colleagues in the hospital that have a vision that we should give every woman the treatment she wants and that is effective. Although there are always domain issues and maybe financial issues, we have come to the conclusion that we should go forward, because otherwise the future will overtake us. So we rather be prepared for the future than that the future is deciding for us. This study, the My Choice study, has the full support of the Dutch Benign Gynecological Society, which I'm very happy with. This was not easy, right? Because every new intervention, it has the potential to be disruptive. And what do I mean with being disruptive? It disrupts the original care paths, the paths of care of certain diseases. For example, we have shown that 60% of all patients referred to the gynecologist could be treated with HIFU. That would mean they will lose 60% of their patients. But we have to recognize that we in Europe have an aging population. We have more work than we can actually handle. And that's a different situation, I think, from other countries. So there's enough work for everybody, and we should just do what's the best for the patient. Second question, we have not done ovarian ablations. I've never done it. And was there a third question? I forgot.
No, it was only two questions.
Okay.
Thank you. Thank you, Professor Martijn. Very interesting lecture, and have a lovely day. We have to jump to the next presentation.
Okay, thank you very much. Have a great afternoon, and see you next year in Cairo.
Martijn, thank you very much. And if you have time, I would like you to also attend this next speaker. If you can just watch it. You would love it. I would like to introduce Professor Lian Zhang. Professor Lian Zhang is the president of HIFU Chongqing